So prior to Blake getting started, from a Taylor perspective, we have this database of over 5,600 procedural consents by specialty, broken down into its own individual categories. And what originally started with this solution, and we've had a huge success rate, not only Epic but other clients using it, the VA, many clients are using it for the reason that we can't keep up with all the regulatory requirements of these procedural consents, especially with leapfrog standards, making sure it's down at a sixth grade reading level. We need help. We need a solution that can provide us that vetted content that can be plugged into, the document itself. So I have all this content. I have one template. I'm pulling that information into that template. So as we started, we supplied a user interface, and then as became more mature with Epic, Epic basically said, "Look, we want to use an Epic eForm. The Epic eForm has all the hooks into all the reporting, the dashboarding, the deficiencies. Everything should be in Epic. So can we detach your content and can we bring it into an Epic eForm?" So we worked with them, and yes, a couple years back, Blake and Shannon was gracious enough to be a pioneer in that, and worked with us to do that import and to utilize our content directly into an Epic eForm. So now what happens, and I'll just pick a quick procedure and show you from a user perspective. What we're doing is we're pulling from our database all of the appropriate information for that procedure, the description, the benefits, the risks. All of this information is in that database, and that's basically going to be an import file for all the procedures to go into an Epic eForm. And now, from an Epic standpoint, we have this import file that can be brought into an Epic eForm and connected. So now, when the user goes into Epic and they're picking their procedure and they're doing what they're doing in their documentation, now all this data can fly into the form. And from there, basically, it's now up to you and your Epic team to decide what are the business rules of that form. Do I lock it down? Do I allow the users to make changes? Do I allow them to bring in dot phrases or smart text into the document? So at this point, I'm going to stop sharing my screen. I'm going to turn it over to Blake Timms, who can go through that end of it, basically from when we provide the content to what it looks like inside that Epic eForm. So Blake, I'll turn it over to you.
Sounds good. So, as you said, my name is Blake. I am our Optime Analyst. I am a little bit of background. I've been with Shannon for 12 and a half years, and I was an operating room nurse for 6 years. So I have lots of experience with paper, electronic, and now the build and Epic. So what you're seeing here right now, we're in a patient getting ready for surgery. We have a consent section here. So really quickly, to generate a consent in Epic, have a quick button here, consent surgical. Click that button, and what it does is it links to the procedures that were ordered. See here, it pulls in the surgeon, pulls in our diagnosis, which I don't have one on this one, the procedure, our blood questions, and our risks. We have this complication sections. At Shannon, we decided to not allow our physicians to adjust the risks we got imported from IMED. We only allow them to add what's already there. So this can be a dot phrase, smart text, type what you want, and it will get entered in there. Fills in right there. And then down here at the bottom, we have our signatures. You can lock these down. As you saw up here, we had this where it was hard stopped. It locks down the signature so no one can sign until all the required questions are answered. When we answer that, this unlocks everything. You see you have 3 required signatures with some additionals. So our provider. So one thing nice about Epic, our legal team allowed click to sign. All our physicians have credentialing individually, and everything is tied to that. So if a nurse is logged into the consent and the physician needs to sign, click edit and they can sign. It'll change who is signing the consent at this time to the physician, but it won't kick the nurse out of Epic. So that has been useful on our end. Same thing works for patient. They have click to sign. You can sign on screen with the mouse, and Topaz machines as well. But here. And then witnesses, how we currently do consents in Epic, or for the patient, sorry. For patients, we use Welcome tablets, which is an Epic application. We use Welcome. You can use Haiku, Canto, Rover, MyChart, and now you can even send it to their device using this QR code down here, so they can scan the QR code from their phone and get it on their own device to sign. So when everything is signed, click accept, and it comes here. You can see it's e-signed. If you have 2 of the signatures, it'll say 2 of 3 signed, letting you know you have more to get. This section right here is shared between intra-op, or pre-op, and our physician's pre-op workflow. So if it's generated in one section, it comes to all 3 of them. So a little bit of how the background works. So we get an import from IMED. It brings in all the information. So this is our lap chole procedure on our consent information. It brings in all the information down into here to puts it in this little free text field. Not going to pull up. From there, we created a e-signature template where you have all your smart links. You have your smart links for surgery, for the diagnosis. This procedure is linked to a smart form. And then our blood is right here for Texas risk and just generic risk. Throughout here, you have different areas where you can have questions. So like this is a data field that's a checkbox that you select what you would like. For blood, and of course your signature fields are down here. So that is a quick overview of our ORP-based procedures. Are there any questions currently?
I think Dr. Smedley, I think I see you talking. You're on mute.
Sorry, I thought I pushed the button there. But Dr. Jones, I see you're on. Did you have any questions or thoughts or things that you wanted to see specifically?
No, I think you really showed me what I wanted to see was that with this template, it basically fills everything in, and all I have to do is sign it afterwards. That's kind of the goal. This makes it much simpler than what we had saw the other day, the normal Epic way. So.
Yeah, can we see that again though? Kind of went by a little quick, so I couldn't keep up with it.
And this can be Blake, this can be initiated by a nurse on the team.
Correct.
Okay.
So this can be done at any part of the process as soon as the case is ordered. So the office staff can even generate this. We have it in our prep for case workflow, where after they generate the case request, they can generate a consent and link it to the case. So it's just as easy as clicking this consent button here at the top, and it pulls everything in from the case request.
Yeah, that's a great question,
So,
Warren. That's one of the current workflow would be, let's say I have a patient in the ED that needs to have their gallbladder. The surgeon comes down, sees the patient, and then writes an order to, he's already saw the patient, he's done his consent, done his discussion, but he'll oftentimes say to the nurse, consent the patient for a laparoscopic cholecystectomy. So the nurse could then go in and institute this, talk to them about blood and the other things, and we could get all this and check all this. Then the physician just has to sign it, correct? And the patient.
correct.
Witness.
Yes. And we actually have that happen, and whenever the consent is generated, they can go on Haiku and Canto on their phones or tablet or whatever they're carrying around and sign straight from there.
And it's pulling the procedure in from where in the record. I think we went over that last time, but that's not a search.
It's pulling from the.
It's just a.
So it's pulling from the case request that puts it into the procedures here. So like if I were to add another procedure here, and I go back to consents, the ones we already generated won't have that on there, but if you generate a new one, it pulls lap appy on there, And then you have all your risks, and it's separated out and let you know which one is pertains to which procedure.
So the surgeon has to basically put it in as a procedure. He says, I'm going to do this. He puts the order in. Hey, I'm fixing to do an appendectomy. Then it's automatically available for the nurse to go ahead and consent for the procedure that he posted.
Correct.
And it looks like there would be choices depending on the particular workflow of the OR, the procedure room. You could have it done on a tablet. You could have the signature done on a tablet. You could use the QR code to have the patient sign it on their own device, or actually print it out and then have it a paper signature and then have it reloaded back in later if you had the need to do that for some reason.
Correct.
And that's kind of the same at UAB as current state. I mean, we get consents formed electronically with iPads.
Blake, I know in previous presentations, you mentioned you could even scan the patient's wristband and it will pull up the consents. Is that true?
Yes. So 2 ways to get the consent to the iPad, at least with welcome. You have a little button here. Once all your questions are answered on your smartphone, you can click this. It generates a QR code and will pull up the one consent you selected. Or any consent that needs to be signed that's available for the patient to sign. If you scan their armband, it'll pull up a list of consents ready to sign, and you can get them all signed at one time on the iPad.
So using the iPad can be used to scan the wristband, and then that will pull up all the open consents.
Yes.
Deal. So I think the concern in the last presentation, Blake, was that a lot of data input. There just seemed to be a lot of confusion around what gets pulled in versus what has to be entered into that eForm. For all intents and purposes, you have the blood requirement to answer the blood question, but then once that blood question's been answered, you go right to signature. So the idea is to
Correct.
pull that vetted data directly into the form.
Yes. And depending on how you have full control on building these consents how you would like. So your person can build it exactly to your specifications. Any additional questions you want, you can add on there, whatever your state requires. This is all customizable by you. With IMED, you just you create smart links to pull in the sources of data that you want to pull into the consent itself.
Blake, I have a question for you. We've had over the last several months among the chief medical officers and others as well, some back and forth discussion over whether having too much information or too little information in one of these forms, and then kind of what's the right balance between too much and too little. Have you had any discussions like that among your faculty, or pushback from physicians, or any questions about too much information or too little information?
So the one thing I've heard about, at least recently, is too little information, because the state of Texas changed some of the requirements for their procedures for mandating what's required on the consent. So our stand is, if all the physicians who use that consent agree on a change, we can change it. So like in this case, we're doing water jet ablations of prostate. They removed some of the risks associated that, like with incontinence. So the urology group is getting together to determine if they want to add that back to the consent. And once I get a confirmation, I will speak with our HIM director, who technically owns the consents. I just build them in Epic, and get her confirmation to build it into Epic.
Then how does that work with Taylor Health content that flies in? Because I thought I understood, Mike, that your content is kind of generic across all of your customer platform. But it sounds like from Blake's perspective that there is the ability to sort of customize for for a facility.
And Blake, I'll let you talk, but yes, we're providing that content, and then to Blake's point, you decide if you're going to use all content or are you going to edit or filter certain procedures from that. But I think one thing that may, I guess initiate is a conversation with our content team. So if you are removing content or challenging it, that spurs a conversation with our team to say, okay, let's rethink, let's look at this, let's understand why you feel it should either be removed or you need to add information.
Holly Bell, I think you were in one of those conversations about are we putting too much in? Is there the potential to put too much in? And I don't know.
I think that's the question is, how much do we want in? What risks are actually being discussed specifically with the patient at the time? What type of an opportunity review time do they have, the patient, to review this list? Because it does seem like there's a lot of content, and I don't know that the physicians are necessarily going to be detailing each and every one of those things. So, but maybe, Blake, you may have some feedback on how that works from the physician side in terms of those discussions.
So from our side, our HIM director met with both of our CMOs and CMIO and determined that whatever IMED gives us has to be on the consent. That's not negotiable. And then Texas have requirements as well. So the Texas requirements have to be on there. So even though these risks aren't necessarily discussed, our workflow is whenever a nurse gives it to the patient to read, review, or if it gets sent their my chart, if they have questions, we get the physician to come back and discuss it more with them because it wasn't clearly discussed with them in the first place.
So does this, when you're building the risk benefits and alternatives, is that standardized? So everybody who does a lap chole or a lap appy has to use the same RBA?
Yes.
Okay. And that's what you were talking about earlier, that if something had to be changed, the whole group has to approve the change. Everybody that does that procedure has to approve the change. Okay.
In the basic form, but you can modify right here on this screen per patient, per procedure.
So yeah. So like right here, we have this complications section. So if a physician wanted to add more risk and complications to the surgery, they could have a dot phrase they can put right in here specific for them, and they can place it into the consent.
So Matt, would this be similar to what you showed the last meeting? These documents would be in those RBA sections, but then if there's something else that they wanted to add, they could either add it in the box or on the form?
Yeah, that's correct. So we have a similar idea. This is an older version of Epic, but ultimately we do have that smart form on the side that Blake has his cursor on, so pulling in information.
Okay.
Tenson's got his hand up.
Yeah, so mine's not specifically into the content about what's in the informed consent, but I'm thinking of how was the procedures laid out in regards to like levels. I'm thinking of like some type of spinal surgery. I mean, are we going to have it to where there's a different procedure for, a fusion of L4 and 5? I mean, because that's a joint commission requirement. We even kind of use that in our timeout process. So
our surgery procedure, our surgery scheduling procedure list is everything. I mean, it's they're by CPT code. And so if there's something that the surgeon specifically wants to put in there, that will be included as part of the procedure. But all entities will be scheduled by CPT code. And then
to answer your question, yes, it's by CPT code, but the levels are required because it's required here. The physician on the procedure description writes the levels in, and when the procedure consent is created, the levels come in just like this.
Thank you.
Dr. Smith?
Hey guys, listen, thanks for your time this morning. Let me change gears and just ask about another work process, and that's just an elective case. So I don't really care about the procedure, hip, gallbladder, whatever. But let's say the doc can use the iPad in the office, and let's say it's not 30 days out, but let's say it's 28 days out. The surgery is scheduled for 4 weeks from the office visit. So can the doc pull the pad down? Can they, pull the description or the consent, add anything that he or she wants to the consent, and then share it with the patient and have them execute it there in the office? It then goes and lives in the portal, right? I think, or could, so that the patient can refer to it or show it to his wife or daughter or son when they get home if they wanted to. And then is it done? Is that consent complete and sufficient for the hospital's purposes 4 weeks hence when he shows up for his hip surgery?
So in state of Texas, 30 days required is the maximum requirement, so no more than 30 days. So if the physician reviews all this, gets the patient to sign, it attaches to the case and lives on the blob server. So when the case comes up, the consent would already be signed and ready to go.
So there's no exercise in pre-op holding on the day of the surgery and none of that. It's done. It's okay. I picked 28 for a reason, because most of our H&P requirements, hinge on 30 days too. So if that's, we probably can use that. But okay, so this obviates the problem for the doc and for the hospital by getting this done. And can the doctor save it in their pad or whatever they're using in their office so that they don't have to recreate it? I know there's some special one-offs occasionally, and they may feel strongly about a risk that they're going to mention to everybody, but they can save it and pull down that's their same consent for the next patient.
So this is all generic. So they would have to create it in Epic first. They can't use the iPad to generate the consent. So they generate it in Epic, but all they would need would be like a dot phrase to change it. So if it applies to one specific patient, just the dot phrase would go here, it'll apply it to there, and then you can get it on the iPad to sign.
Okay, but do they need to do that with every patient? That's, I guess, my question.
Yes, they would.
If they want to see it, they're okay.
Yes.
Okay, thank you.
You're welcome.
Hey, Blake, I know you mentioned previously from a Shannon perspective, your case matching. I might be getting this wrong, but you're upwards of 95%, correct, as far as the consents now matching?
Our procedure link accuracy has drastically increased with going to consent in Epic. It requires the physician to select the correct procedures to consent for the correct thing. So therefore, when it comes to surgery times and the time it takes for surgeries, it's getting more and more accurate. The last time I checked, we were in the 98th percentile on our Epic dashboard of case link accuracy within 10 minutes.
Thank you. And that would be something, Dr. Smedley, in your scenario, if you were to either use paper or that could deter from that dashboard. So
I think the vast majority will be done electronically, but there could be situations where there's a private practice physician and for some reason the way the procedure workflow is set up, it needed to be done by paper. I was just pointing out that there are multiple ways to get it done, and it can be modified. The process can be modified to fit whatever the existing workflow is.
Correct.
And then if that external provider uses, I believe it's Epicure links, consents are coming, if not already there, for Epicure links. So you can generate it for them and they'd be able to sign from that.
I think the one thing, I think to Dr. Smith's question is that if you're consenting a patient 3 weeks in advance in the office, the way that Epic works, it appears to be the way that Epic works, the case has to be scheduled or requested or ordered before you can generate the consent. Is that right?
Correct.
So, Dr. Smith, we would need to, if this is a private practice physician, we would need to figure out how we get them to place the order so that there's actually a consent form in Epic that can be generated.
Yeah, I get it. And I think, that is going to be, I won't say problematic, but something to be addressed. Because I think a lot of people leave the doctor's office thinking, hey, we're gonna get all our stuff done, and then basically pick a date based on whatever you've got going on, patient, or whatever the doctor has going on, things like that. And sometimes it's 6 weeks out, and that's the other issue we'll have to deal with, and that is if they execute a consent and the procedure ends up being more than 30 days out, in all likelihood they're going to need to redo it or do it again.
Could PAT be
Sure.
the catch
Sure.
for that?
For the most part, we're catching that same day surgery when they come in, right? They're doing their discussion in the office and they show up to same day surgery. Same day surgery would activate this consent, get the patient to sign it. The surgeon has to sign it prior to the procedure, but they're doing their discussion in the office. But I don't think most of my physicians are actually getting the consent signed until day of in same day.
Yeah. But it would be sitting there ready to go, so it wouldn't be a long process to just open it and sign it.
Yeah,
It's
it's
what they're
actually
on.
easier this way. They can sign it anywhere they're at in the hospital, right? They don't have to be in same day the way we make them do it now.
Yeah, and I just want to say, talking about the 30 days, we should be doing that right now with our current process. We should be accepting 1% greater than 30 days. So,
I don't think we are, Tenson. I think it goes along with that. Like I say, our workflow really is to get that signed in same day for the most part.
kind of along those lines, though, with the PAT, is there an opportunity to send this form consent through like the patient portal? Have that with their paperwork was signed previously? Before they show up?
No, but PAT could start this and get them to sign it at PAT if they come to PAT.
So you can send it directly to my chart for the patient to sign as well.
Does it require a witness?
Yes, it does. But everything on a consent, I can tell you in Epic is timestamped, and I can pull everything out with what device they used, where, and how. So that's kind of helpful a little bit.
Getting back to the 30 days, it would tell us, right, if someone did have it over the 30 days. Just say.
So this section right here only shows consents within the last 30 days.
Okay.
So if it was more than 30 days ago, these wouldn't show up at all. And then inside some of your settings, you can make these expire at 30 days as well.
Hey, Blake, it's Mike. I know you mentioned previously mobile sign is coming in Epic, where I think February release will have a mobile capability for a patient.
That is already there. So they can use their phone with this little, it's not working here because this is a test patient, but you have this little code down here. You click this, it'll launch a QR code the patient can sign with their own device.
Nice. Any other questions? Hopefully this helped with, at least clearing up some of the concerns with the workflow. Again, Blake's been using it for a while now and is crafted it around, the user perfect, their preferences. So this is an active form that's in use, and it's been in use for about 2 years now. Any other questions?
Going once, going twice. Well, thank you to everybody for joining in. We had great turnout today. Thank you for carving out time. If you have follow-up questions, send them to me and we can get them to the right person.